first thing that I wanted to say is that for those of you who have read or are familiar with the figure from the 2003 IOM report on the future of the public's health in the 21st century, you'll notice that the figure on the right was prominent in that report, and that was dubbed the public health system. And you'll see that in the middle of it is something that says assuring responsibility for conditions for population health. And there were many actors around that particular circle. This committee felt like we wanted to do something that was a little bit different. We wanted the figure to look sort of similar, but to change the context a bit. And so instead of talking about the public health system, we really wanted to talk about the health system. And by doing that, and I kind of hope that this will catch on, at least in this crowd, we wanted to sort of stop making that division between the medical care delivery clinical system and the public health system, but rather to get the public and to get policymakers to thinking about the health system in aggregate, and making people begin to be a little bit more cognizant of the idea that the medical care delivery system is actually responsible for a relatively small proportion of the health of the public. So we accordingly renamed it, and in the middle we've put governmental public health agencies, because the role of convening, of communicating, of leading, we think is fundamental for public health, and we wanted to make that argument as strong as we could represent figuratively. The committee was also very much, continues to be in the mindset of thinking more about the social determinants of health model and using that as our platform going in. I think Scutch has a piece in the American Journal of Preventive Medicine in January this year, where I believe it is he who talks about a sort of a transformation from the infectious disease paradigm to the chronic disease paradigm to the social determinants paradigm. And I think many of us in public health are very persuaded by that. We really want to take the focus away from the biomedical model, which really is talking at the sort of genetic level and perhaps gets to as far up as the individual behavior, and contextualize the reason why people have behaviors in the communities they live in and the factors that are outside of individual control that need to be acted upon to create a healthier society. And as the evidence base has increased about the social determinants as being so important in creating health or its absence, we think it's time to sort of move that conversation further along. So measurement. We decided to start with measurement. The RWJ gave us a little bit of leeway. We were originally going to start with financing, but we thought measurement is really an important place to start. And for social environmental determinants, measurement allows us to think about the mechanisms of action and the interventions that are effective in ameliorating disadvantage in health. And if you want to, in fact, change the conditions for health, you have to begin with measurement, because what you measure will describe the challenges you have. What you measure can create understanding. What you measure can galvanize action. Doesn't always, but it's harder to ignore. What you measure, you can facilitate mutual accountability, and you can therefore record progress or lack thereof. So the committee heard repeatedly during its information gathering sessions that the nation's health information systems are overly fragmented, too often untimely and inaccessible to decision makers. The decentralized characteristics and its propensity to let 1,000 flowers bloom may be too many flowers to bloom in terms of the indicators. It makes understanding associations and causality challenging, particularly at the local level, and it can detract from decisions about priority setting. I think Lisa Simpson sort of indicated that issue of trying to comb through all of the evidence in her talk at lunch today. In addition, there's a lack of alignment between national data gathering priorities and what's important at the local and community level. In the federal health data sets, there's an emphasis on medical conditions and distal outcomes rather than actionable intermediate outcomes, leaving government, public health, and the larger community of actors without adequate guidance sometimes as to what interventions are going to be most useful. Despite the data warehouse efforts that are starting in open government, information on determinants coming from other sectors of government data sets, such as agriculture, commerce, transportation, education, are often underdeveloped in terms of the linkages that are really needed at the community level to make sense of what to do next. So the committee believed that we needed a stronger centralized capacity for health-related information. And again, for those of you who are very interested in the details of the report, there's a lot more information in the report itself. This is a kind of once-over lightly. So accordingly, the first recommendation was that the Secretary of Health and Human Services transform the mission of the National Center for Health Statistics to provide leadership to a renewed population health information system through enhanced coordination, new capacities, and better integration of the determinants of health. And I think Ed talked about some of that this morning. The committee also saw the vehicle of the National Prevention, Health Promotion, and Public Health Council, which is established by the Healthcare Reform Act and is composed of 12 cabinet secretaries and agency heads under the leadership of the Surgeon General, as a group that had accountability and needed to report by law to Congress on an annual basis about their national prevention strategy. So accordingly, the committee asked that that council report to Congress annually about the progress of the National Center for Health Statistics in achieving a sort of a transformative mission. A number of the other recommendations the committee put forward are predicated on a strengthened NCHS with greater capacity.